Dr. Chamara?
Hi, hi, Surat. Yeah,
Hi, Chamara. You were introduced. The floor is yours.
Okay, sorry, I did not hear that.
Probably, yes. I thought so.
When did that happen?
A little while ago.
Okay, just bear with me.
No worries, no worries. Take your time. Before you begin, Chamara, just let me add in a word. If anyone has any questions, please text them to me during the lecture, and afterwards, of course, the floor will be yours to ask Dr. Chamara as many questions as you'd like as well. Thank you. Go ahead.
Okay, thank you very much, Sunit. I'm sorry, I did not hear that introduction, so my apologies for the late start there. I was actually waiting for a cue there. Anyway, at the offset, let me thank the College of General Practitioners for inviting me for this lecture. It's always a pleasure and it's definitely a privilege to talk to and share some knowledge. So the topic that I was asked to talk about today was quite a pertinent topic, something that's quite commonly spoken of as well, I guess, with the COVID-19 pandemic, hopefully past its peak in our country as well, but it's something that we still talk about, but unfortunately it's something that we are dealing with even now. So I was told to speak about the cardiac complications or the heart complications of COVID-19, which pretty much is a very broad topic. So I'll try to make it as short and sweet as possible and less complicated, and with room to answer questions, which I'm pretty sure a lot of people will be having as well. So let me start off with this little quotation from a very famous gentleman by the name of William Osler. I'm pretty sure everybody would have heard about him. He's considered the father of modern medicine as well. Lived in the early 20th century, actually. So even during that time, he was quoted to have said, "Humanity has but three great enemies: fever, famine, and war. Of these, by far the greatest and by far the most terrible is fever." So, you know, a couple of years ago, maybe even 2019, 2018, if we had actually read this, we probably would have laughed, thinking, what rubbish is this? Fever being the most terrible and by far the greatest, by far the worst of all the possibilities of famine, war, and you think it's fever. But, you know, given the last 2 years, what has happened to the world, I think it was almost prophetic of him to have said these words in the early 20th century. The way that this pandemic has affected the world over, not only our country, all over, it's definitely, I think he was quite accurate in the way that he said that fever, probably of all of these great evils, is probably the worst of them all. So just to give a short roadmap of the Sunet, if I could just trouble you for 1 minute, if you could just request the audience to maybe mute their Zoom call in. I think that might make it a little bit more clear, isn't it?
Sure, Chamara, of course. Everyone, if you could please mute your mic, we would appreciate that because it causes a bit of a disturbance.
Could hear a little bit of disturbance. I think probably will cause it might
I'll
be.
do from my end, Chamara. Hold on.
Thank you. So yeah, just a short roadmap of what my plan is today as to what we'll be talking about. So let's just talk a little bit of the disease burden. So as far as cardiac complications is concerned with COVID. So basically the cardiovascular complications. So basically the complications of the complications that we speak about sometimes are actually the tip of the iceberg, which we'll elaborate a bit more. The mechanism as to how these complications do occur. And then I will speak about a few of the specific cardiac complications, the diagnosis, management, and prevention of those. So in particular, I'll be talking about the acute coronary syndromes affected affecting COVID patients, myocarditis, and stress cardiomyopathy, which are the three most common cardiac complications of COVID. Thromboembolic diseases are also part of the whole spectrum of complications, cardiac complications, but due to time constraints, I do not think I can speak of that as well. So we can answer questions if there are any about it, but I will not be talking specifically about the thromboembolic complications. And lastly, and I think this is very important, to talk about the so-called collateral damage. Again, I will elaborate a bit further on as to what this means, but the collateral damage of COVID and its cardiovascular implications. So that's going to be pretty much the road that we are going to take in the next few minutes. And hopefully things will, I will be able to enlighten you on the scenario so far as cardiac complications of COVID-19 is concerned. So pandemics are not that uncommon to this world. We've been dealing with pandemics since the 14th century, where Black Death was, or the plague as we call it, was introduced. And COVID-19, which we are dealing with in our lifetime, if we are looking at the burden as far as death toll and percentage of the population that it has affected is concerned, we can see that you know, in the early 14th century, where Black Death was the pandemic that was raging, it basically wiped out about half of the world's population, 51%. That's staggering, isn't it? So compared to that, COVID-19, the pandemic, has wiped out about 2.3 million people, which is definitely a considerable amount of deaths, especially if it's somebody close to you. But comparing to all the other pandemics that the world has endured over time, we can see it's not, the percentage-wise, it's not even AIDS, which is basically a pandemic, I guess, which we are still dealing with, has killed more people than COVID-19. So why is it so? Why is it so significant for us? Obviously, it's because of the fact that this is something that we are living in, we are dealing with, we are in our. It's something that's in our own lifestyle. Is somebody who's drawing on the screen, but anyway, Sunita is somebody who's drawing on the screen, which may be unclear for the others, but anyway.
Let me take care of that. Hold on.
That's all right. Basically, so as the probable reason is because it's heavily impacting the world economy, and that's something, you know, right throughout, not only in our part of the world, but, you know, right throughout the world economies have crashed because of this pandemic, and that has probably affected most people, including yourselves, and that's probably why we are talking about it more, with the media being involved, etc. Definitely, it's something. It's the whole world is definitely talking about it. I don't know how to get rid of those lines that somebody has drawn, Sunit, but anyway, hopefully it's not.
Chamara, neither do I. I'm trying from my end. I think maybe if you reload your screen, just reload your screen, that might work.
Let me just see.
In the meantime, let me reintroduce Dr. Chamara, because I got a number of texts saying that the introduction was not heard. So yes, in the meantime, Chamara, let me do this again. So Dr. Chamara Ratnayake is the resident cardiologist of the RCD group, and he is going to speak to us on a topic: COVID-19 taking lives and breaking hearts, which is basically a very timely discussion on the cardiac complications, as well as on the complications that can happen from COVID-19. Also, as I said earlier, if you have any questions, please text them to me. And in the meantime, you will get the floor once Dr. Chamara is done to ask him as many questions as you like. Thank you. Right, Chamara, the lines are gone. The floor is yours again.
Thanks, Sunit. Yeah. So basically, as I was saying in the roadmap as well, this whole iceberg effect So when we talk about COVID-19, so what we see actually, as far as patients are concerned, confirmed cases with more severe disease, for example, is essentially at the tip of the iceberg. Severe disease and deaths that are, every day we hear and we get the text messages, isn't it? This many deaths, this many patients diagnosed, etc. But to be quite honest with you, it's essentially the tip of the iceberg, because what we don't see are the unconfirmed cases, mild to moderate diseases, and the so-called asymptomatic COVID-19 patients. So these are the undercounted for numbers that, basically we actually don't see and don't know the exact number of patients who actually are having COVID-19. There's another line again from somewhere again.
Chamara, just switch off the annotation so then nobody can write on the screen.
Okay, let me see.
I think it was done from your end.
Is that me? Right, let me see how to switch it off. Not too sure how to switch it off.
Myself, Chamara, to be frank, I'm also looking for it. Let me see what I can do from my end so I can sort this out in a minute.
If you could do that, yeah. Anyway, yeah, so as far as cardiovascular complications are concerned as well, so what I wanted to talk about is basically is that even the cardiovascular complications, so all the myocardial infarctions and etc. that we see as far as complications of COVID-19 are concerned, that also what we consider are, again, tip of the iceberg. The ones that we don't see, which again at the end of my lecture, which I'll be talking about, are the so-called collateral damage, the collateral cardiovascular complications of COVID-19 as well, which is probably even more problematic, and that's something that we probably ignore and we don't see. But the amount of damage that COVID-19 has done to cardiovascular medicine altogether is insurmountable. It's really, really scary sometimes when we hear the proper damage that COVID-19 has done. So basically, let's talk about either side of the iceberg, the tip plus the collateral damage. So as far as direct cardiovascular complications of COVID-19 are concerned, so that's pretty much the topic at hand. So if I were to elaborate a bit more, so anybody could get complications from COVID-19, including cardiovascular complications, but there are certain category of patients who will be at higher risk. So please bear in mind that I just want to tell you that is that at the offset of the outset as well, rather, that just because you don't have any of the risk factors, that does not immune you from getting cardiovascular complications, but those who have these risk factors are more prone. So older age, obesity, hypertension, diabetes, cardiovascular disease in the sense those who have previously diagnosed cardiovascular diseases, cerebrovascular diseases, immobility, critical illness, and chronic respiratory diseases. So people who have already been diagnosed with these type of complications or diseases are considered to be at a higher risk of developing cardiovascular complications of COVID-19. And what are these complications? So we can see the prevalence of these as well. So thromboembolism is very common, again, affecting approximately quarter of people who have diagnosed with COVID, and again, a mortality of almost 23% as well. So that's quite a significant proportion of people who can develop complications as well. Acute coronary syndromes, again, you can see the prevalence is not too common, isn't it? It affects only about 1% of people who have had COVID-19. But the problem is, even if you do develop an acute coronary syndrome during COVID-19 infection, your mortality is about 27%. So that is quite a staggering percentage as far as mortality is concerned. Myocarditis, again, quite common, isn't it? Prevalence of about 36%. That's probably the most common, or one of the most common complications of COVID-19. And if you do develop myocarditis, the mortality is quite high, more than 50%, 60% actually. There is a high mortality rate there. Heart failure and cardiomyopathies, again, about 1/3 of patients who develop COVID-19 are prone to develop some sort of a cardiomyopathy or heart failure, with almost 50% mortality there, 47. And arrhythmias, again, common complication, 17% prevalence with a 20% mortality. So the ones that these are the ones that we commonly see. And of all of these, you can see the myocarditis is probably the biggest killer and the most prevalent of the cardiac complications. So that's what we will talk about a bit later as well. And you can see that patients who develop these complications are majority are in ICUs as well. So the venous thromboembolism or the arterial thromboembolism, major adverse cardiovascular events, and symptomatic venous thromboembolism, majority of the time are seen in patients who are in ICUs, or essentially in those who have more severe COVID-19 infections. So because we obviously admit those with more severe COVID-19 to the ICUs. Those who are non-hospitalized or non-ICU, basically those who are with COVID-19 and are treated at home or in wards, in intermediate care centers, for example, you could see that the prevalence of these complications are much, much less. It's about less than 3%, isn't it? And as far as thromboembolism is concerned and major cardiovascular events are concerned, it's about there's something there. Let me try that. So let's just try to show me how to get this annotation done. Let me try that.
Right. I sent you.
Yeah. There you go. I hope that's sorted. Then I did.
Hopefully, yeah. Hopefully that should sort it out.
Yeah. Hopefully, yeah. Yeah. So basically, the story is that patients who have more severe COVID-19 are the ones who are more prone to develop these complications, including cardiovascular complications. Just a short slide on the mechanism. So I don't want to elaborate on this too much because it's kind of boring and it's not going to be very important as far as we are concerned, as far how as far as lecture is concerned as well. But I think it's important also to have a basic idea as to why these cardiac complications do happen in certain patients. So if I were to try to make this slide a little bit easier, let's start from one place and move to the other. So as far as acute coronary syndromes are concerned, so that's what that's my expertise, and it's something that I like to deal with day in and day out, not in COVID patients obviously, but in general. So how do they develop acute coronary syndrome? Generally two ways. It's either a rupture of a plaque, so that's what we call type 2 myocardial infarctions, the common myocardial infarctions that we see, the ST elevation MIs, for example. If there's a rupture of a plaque, atherosclerotic plaque. But also remember, there's a different type of myocardial infarctions that we deal with. These are the so-called type 2 myocardial infarctions. And these type 2 myocardial infarctions occur in patients because of a apparent oxygen supply and demand mismatch. So this mismatch of oxygen and supply and demand basically could be due to many reasons in COVID. Hypoxia, because if your lungs are affected, which is quite common in COVID, obviously you get a COVID pneumonia, you develop hypoxia, and in return, obviously, there is an oxygen supply and demand mismatch, and this could lead to a myocardial infarction independent of whether you have pre-existing atherosclerotic cardiovascular disease. Increased metabolic demand. So again, patients who have COVID-19, they have fever, they can obviously have increased metabolic demands. Again, because of that, the demand is higher than the oxygen supply, and they can also end up with the so-called type 2 myocardial infarction. Hypotension. So patients who have got COVID-19 very, very commonly have also got concomitant sepsis. That's quite something that we see often. So because of that, because of the sepsis, most probably they develop hypotension. The blood pressure is low. Again, the supply of oxygen is low and the demand is high, and there's that mismatch leading to type 2 myocardial infarction. So these three conditions, hypoxia, increased metabolic demand, and hypotension, and sometimes all three together, almost a perfect storm there, leading 2 myocardial injury and type 2 myocardial infarction. So that's pretty much the acute coronary syndromes mechanism. But apart from that, we spoke about myocarditis. So how can you get myocarditis with COVID? It's quite simple. There is the commonest reason is direct viral cardiomyocyte toxicity. The virus goes and damages the heart muscle, leading to myocarditis. Quite a dangerous situation, and that's probably why there's such a high mortality as well, because if it does happen, the myocardial function obviously is impaired and it can cause lots of damage and myocardial injury. Apart from that, you do get myocarditis again from a hyperinflammatory state because of the so-called cytokine storm, as we call it, of COVID-19. And because of this hyperinflammatory state, you could also get direct myocardial injury, myocarditis, etc. And along with that, the so-called stress cardiomyopathy. I will elaborate on this a bit later as to how it presents and how we diagnose it, etc. But again, stress cardiomyopathy, multifactorial, but the so-called hyperinflammatory state also is something that can lead to it. And another one that we speak about very often during any viral illness, again, is microthrombi and disseminated intravascular coagulation, probably leading to microvascular dysfunction, again, causing myocardial injury and different types of cardiac complications. So essentially, all of these mechanisms could lead to myocardial damage and cardiovascular complications because of COVID-19. So basically, we have gone about halfway through the road that we spoke about. So the next steps that I will talk about are the so-called specific complications of COVID-19. So as I mentioned, the specific ones that we will deal with, the ones that I will talk about, the so-called acute coronary syndromes, myocarditis, and stress cardiomyopathy. We will not talk about thromboembolic complications because of the time constraints. So the so-called acute coronary syndromes, let's talk a little bit about them. How do we diagnose it and how do we deal with them? So before we speak about the acute coronary syndromes, I just wanted to elaborate again that of the thromboembolic complications, so if you talk about thrombosis, we could get on either side, isn't it? We can get venous thromboembolism as well as arterial thromboembolism. And studies have shown that because of COVID-19, the more prevalent type of thrombosis is actually venous thromboembolism rather than arterial thromboembolism. It affects both sides, but venous thromboembolism is more prevalent. But obviously, acute coronary syndromes are usually because of arterial thrombosis. And how does this happen? So if you talk about normal circumstances in day-to-day life, without this whole COVID-19 pandemic, let's say, what happens in patients who have atherosclerotic plaques, they initially tend to have chronic coronary syndromes, or angina. Stable angina was the older term. Now we call them chronic coronary syndromes, along with diabetes, obesity, etc. And because of the chronic inflammation, this plaque ruptures, and that leads to acute coronary syndromes. However, because of this COVID-19 infection and the so-called cytokine storm that is associated with it, what happens is there is a meta-inflammation or a hyper-inflammation scenario where the plaque rupture occurs more earlier rather than you would expect it to occur in a general in general population, essentially. So we get, and we have noticed that we are getting quite a lot of acute coronary syndromes in this day, in the current pandemic era rather than in the previous years. And the most likely reason is this whole meta-inflammation or hyperinflammation status caused by the cytokine storm, and you get early plaque rupture causing acute coronary syndromes. So how do we diagnose it? So I always follow the same principle in all my lectures and all my teachings as well. To make a diagnosis, we go by the so-called stepwise process. So history, symptoms, signs, and then we go with the investigations, and then we go for treatment. So symptoms and signs. So basically no different here. Just because the patient is having COVID-19, the symptoms will pretty much be the same. The patient will come to you with quite significant ischemic sounding chest pain. I don't have to elaborate on this more, I think. What we know what ischemic chest pains are like. There usually is autonomic symptoms associated with it. And more often than not, there will be some sort of hemodynamic instability. The blood pressures will be low, heart rates will be high, etc. So pretty much no different here. The symptoms and signs of acute coronary syndrome in COVID-19 will be the same typical type of chest pain that we deal with. So 3 things as far as investigations are concerned that will help in our diagnosis. So ECG, the cardiac markers, and an echocardiogram. So the ECG in an acute coronary syndrome, again, pretty much the same that we see in other patients as well, isn't it? So if, two possibilities as far as acute coronary syndromes are concerned. You can get patients who have ST elevation myocardial infarction. The top ECG there, you can see that there are typical ST elevations, convex shaped ST elevations, V1 to V4 there. So pretty much what we call an anterior STEMI. So quite a significant ECG there, obviously. So COVID-19 patient will have pretty much the same type of ECG. Bottom ECG is a patient who has a non-ST elevation myocardial infarction, where we are seeing more ST depressions in leads 2, 3, AVF, and V3 to V6 essentially. So no surprises there and nothing out of the ordinary. The similar type of ECGs that we see in non-COVID patients will be seen in COVID patients as well. It's just about identifying that your patient is indeed having a myocardial infarction, either a ST elevation myocardial infarction on the ECG or a non-ST elevation myocardial infarction. What about the cardiac markers? So essentially it's the same again. We look at the cardiac markers and we look at the troponin levels. And the important thing there is, I'm not going to talk about, the time durations, etc. We know about them and etc. But the thing about troponin levels in COVID-19 is that the cutoffs that we use are a little bit more different, because the standard cutoffs will not be the usual myocardial infarction cutoff. We have a bit of a lower threshold to diagnose it, and what we find is that the higher the cutoff and the upper limit of normal, the survival is less. So patients who have higher values of troponin will have higher mortality. So if you do a troponin in your patient, and depending on your upper limit of normal, if the troponin is marginally positive, the chance of survival is better. If your patient is having very high levels of troponin, the survival curve is much worse, and the chance of your patient not surviving that infarction, myocardial infarction, is higher. And then we do a 2D echocardiogram, and that can also be quite significant, and that's quite useful in diagnosing an acute coronary syndrome. What we see in our echocardiograms is a so-called regional wall motion abnormalities. So depending on the coronary artery territory that's involved, we can see on the echocardiogram as well that you can see the so-called areas of the heart that is not being perfused, and you can see that area is not contracting as well as the other areas where the perfusion is better. So an echocardiogram definitely is very, very useful in the diagnosis of an acute coronary syndrome in COVID-19 patients as well. And again, this is just again to elaborate on the importance of troponin in acute coronary syndrome patients with COVID-19. Sunat, if you could ask whoever is to mute their mics again, it'll be great. I do get a bit of disturbance. Thank you. So again, so what I wanted to say in this slide is that the troponin levels again has a prognostic implication. Again, the higher the amount of troponin, the higher basically the survival is worse, and you can see that troponin levels in non-survivors are quite high compared to survivors as far as COVID-19 is concerned. So after making a diagnosis, how do we treat? So COVID-19 definitely has made a huge impact on how we deal with patients with acute coronary syndromes, and most importantly, patients with STEMI, ST elevation myocardial infarction. So the mantra as far as ST elevation myocardial infarction is concerned, I'm pretty sure everybody would have heard about it, is that time is muscle. Whatever we are doing, we need to do it fast, because every minute that we waste, myocardium is lost and the patient can have negative implications. So, but unfortunately, with the pandemic raging, we need to think about our own safety as well, where we need to take our own precautions, and we need to wear all this personal protective equipment, etc., etc. And because of that, there tends to be certain delays in treating these patients as well. So again, what we deal with is how to optimize patient care, and especially at the beginning of the pandemic. I think we've all adapted to certain things now, and we are a bit more comfortable in what we are doing and how to do it. But especially at the beginning of the pandemic, we were all a bit lost at sea as far as how to deal with STEMI patients, especially because we want to act fast, but certain things, bureaucracies, etc., as to getting patients into the cath lab, we couldn't get them fast enough sometimes, and there was certain delays involved, which led to poor outcomes as well. So how do we deal with it? So basically, if your patient has come with a STEMI, I'm just talking to a hospital basically, and they're coming in an ambulance, number one thing is, can we perform primary PCI on this patient? So we need to be able to do this in the correct time duration. So basically, if a patient is coming into a hospital in an ambulance, the duration that we say, if they can be brought, ideally what we say is, if they can be brought to a hospital within 2 hours from an ambulance, we can do a primary PCI on this patient. But can it be done timely, with the considering that we can have approximately extra 60 minutes because of the pandemic delays, putting the PPE on, getting the patient tested. So again, basically the whole patient has to be tested for, because if you are unsure about the diagnosis, sometimes the patient has come with a STEMI to the emergency unit, sometimes doing the antigen test on the patient, for example, takes a long time. So sometimes there is unnecessary delays. So if we think that there is going to be a delay where we cannot take the patient in because of delays, then the treatment is fibrinolysis. So that's pretty much not ideal, let's say, because the ideal circumstance, again, for STEMI patients, we always say primary PCI intervention is always going to be the best outcome. But if we think that there is going to be a delay in transporting this patient to a hospital that has primary PCI capability, or because of, even if they come to a center where there is primary PCI, but there is going to be delays because of certain protocols, let's say, of the hospital, then what we suggest is give thrombolytics, fibrinolysis, and then consider intervention later, because as we said, intervention or whatever, if there's a delay, it's going to have a negative outcome. So we need to give that treatment as soon as possible. But if the protocols are in place, and I think now most of the hospitals have certain protocols in place, we are quite happy to perform primary PCI, taking precautions, of course, wearing our personal protective equipment, and having certain protocols in place to bring the patients to the cath lab as soon as possible within the whole time window that we've been given by guidelines. Primary PCI will always be the #1 choice as far as treatment is concerned. But if we cannot do that, fibrinolysis is a secondary good option. Again, for non-ST elevation MI patients, again, no major change as far as treatment is concerned. Standard care, we give the loading doses of antiplatelets, aspirin 300 milligrams as a loading dose, along with another P2Y12 inhibitor. So clopidogrel is the commonest antiplatelet that we give in this country as well. And remember, there are other antiplatelet agents also available nowadays, especially if your patient is going to come in for an intervention. Ticagrelor available, prasugrel available, but clopidogrel is probably the most common antiplatelet apart from aspirin that we give. And also anticoagulation, quite important. Enoxaparin, it's given quite commonly depending on the patient's renal profile, obviously. 1 milligram per kilogram twice a day. Fondaparinux available as well. Bivalirudin is not available now. There's a bit of controversy with it, so we won't use it very often. And unfractionated heparin, if there is any bleeding complication that we are expecting, for example, we can give unfractionated heparin as well. So again, treatment of non-STEMI COVID patients is pretty much standard routine care. The next complication or cardiac complication that we'll talk about will be myocarditis. Again, as I mentioned in my previous slide, as far as prevalence is concerned, quite prevalent, and mortality is quite high. 60% mortality, as we spoke about, in those who are diagnosed to having myocarditis. Symptoms and signs of myocarditis, again, very non-specific. Sometimes the chest pain, shortness of breath, because they can lead to heart failure as well, palpitations, and in fulminant myocarditis, the patients also could develop some hemodynamic instability. So again, ECG in myocarditis, the commonest ECG that we get is pretty much the one on top. It's a sinus tachycardia. It's quite, there's no specific ECG change per se. As far as myocarditis is concerned, the commonest one is the sinus tachycardia that you can get. So it's not specific, please keep in mind, because a lot of patients who have any infection, including COVID, will tend to have a sinus tachycardia. So sinus tachycardia is not specific to myocarditis, but in patients who do have myocarditis, that's something that we see. The bottom ECG, you can see, it's not the most clearest ECG, I'm sorry. But what I wanted to show that there are ST elevations in almost all leads there, isn't it? 1, 2, 3, AVL, AVF, V1 to V5, V6. So the so-called concave shaped ST elevation that we see here. So this is pretty much a patient who is having what we call myopericarditis. It's a pericarditis along with myocarditis. Again, quite a common scenario in COVID-19 patients as well. So this is another type of ECG that we can encounter. So as far as cardiac markers are concerned, so again, troponin levels, again, higher the value, the worse the survival, similar to acute coronary syndromes in myocarditis as well. Apart from that, another marker that we are using to diagnose myocarditis and more than myocarditis, amount of heart failure is N-terminal pro-BNP. So that's also quite a useful marker to diagnose patients to have myocarditis, and especially if their LV function is reduced significantly, leading to heart failure. So you can see that higher the value of pro-BNP, the higher the amount of myocardial injury, and it's independently associated with all-cause mortality as well. So it's something to consider. So if your patient with COVID-19 has a high BNP level, the prognosis is not very good because, again, it has an independent association with all-cause mortality in COVID-19 infected patients. And the echocardiogram, so you can see the difference there in between an acute coronary syndrome versus a patient who has a myocarditis. If we were looking at this, so this is basically the left ventricle, you can see that the dysfunction of the left ventricle is more of what you call a global LV dysfunction, where the whole left ventricle is not contracting very well, and it's compared to the regional wall motion abnormalities that we see in patients who have acute coronary syndrome. So that's quite a distinctive feature, and it can help us differentiate between a patient who has developed an acute coronary syndrome versus myocarditis, because as I said earlier, sometimes the ECGs and the troponin levels, etc., increase, but the echocardiogram can be quite important and helpful in differentiating whether your patient is having myocarditis or acute coronary syndrome. As far as treatment is concerned, so we can talk about the so-called non-specific and specific treatment options available. So if your patient has developed myocarditis, we can consider the non-specific treatments, because at the end of the day, this patient is having heart failure. So in that case, we have to try and give them the so-called heart failure treatment as well. So diuretics, ACE inhibitors, mineralocorticoid receptor antagonists, SGLT2 inhibitors. I think that's one of the new kids on the block. That's the dapagliflozin, empagliflozin. There's a lot of research and a lot of new evidence that these medications are useful in patients with heart failure, and sometimes beta blockers as well. If the patient is not having acute heart failure or at a later stage of myocarditis, giving a beta blocker also could be useful. So these are non-specific. We are not treating the myocarditis specifically, but this is basically we are treating the heart failure that is associated with myocarditis, and it will lessen the burden of the disease. As far as specific treatment of myocarditis is concerned, unfortunately, there is no hardcore evidence as to what can be useful. There is some anecdotal evidence in certain clinical trials that high-dose steroids and intravenous immunoglobulin may be useful in the treatment of myocarditis, specifically in COVID-19 related myocarditis. Again, these are not in the guidelines, but anecdotal evidence, and we do try to sometimes use it in our patients because basically it'll do more good than any harm, I think, and it's definitely worth trying. As far as specific treatment is concerned, things that have proven to be not very useful at the moment, and there is no evidence to support it. For example, the antivirals, so remdesivir, which is commonly used in COVID pneumonia, you would have heard about it. Again, not useful in treating myocarditis. Monoclonal antibodies, tocilizumab, again, something that we see quite often. We see people who are looking for it, for example, which is useful apparently for patients who are having severe COVID-19 and pneumonia. But again, for myocarditis, tocilizumab, again, there is no proven benefit. So only benefits that have been shown so far with steroids and intravenous immunoglobulin. Again, anecdotal evidence, nothing concrete as far as evidence is concerned. Just a quick word on, because again, this is quite a hot topic, I feel, and specifically, I think now in Sri Lanka also, it's going to be spoken about, is myocarditis, which is associated with the vaccines. So this mRNA vaccine, so that is essentially the Pfizer vaccine and the Moderna vaccine, which are the so-called mRNA vaccines. There is some evidence that it tends to cause myocarditis, and there is some evidence that myocarditis is a complication of this vaccine. And quite surprisingly, the myocarditis associated with this COVID-19 mRNA vaccines are usually affecting a specific age group. We can see the so-called adolescent age group, those who are between the ages of 14 to 22 maybe. Again, surprisingly again, affecting more males, more boys than females. So as far as numbers are concerned, what they're saying is, if you're talking about millions, it's not a huge amount of numbers. And the other thing is, the more important thing that I want to emphasize is that even if the vaccine does cause rarely a form of a myocarditis, it's very transient, and that's very, very important. The myocarditis is transient, and so far there has been no associated mortality with the myocarditis. The recovery is quite swift. Within a few weeks, the myocarditis settles, and there is no long-term sequelae of this myocarditis because of these vaccines. So I wouldn't be discouraged so far as vaccinating these adolescent groups with the vaccine. I think the benefit of the vaccine will again outweigh this risk of myocarditis as well. associated in this adolescent age group. The final topic that we'll talk about as far as specific cardiovascular complications are concerned is the so-called stress cardiomyopathy. And I think it's a pertinent one to talk about because of the topic that I spoke about today as well. So the topic that I chose was COVID-19, taking lives, breaking hearts. And so-called stress cardiomyopathy, you may have heard, is another term for that is the so-called, it's also called the broken heart syndrome. So it's something that is quite significantly affecting COVID-19 patients. So quite literally causing broken hearts as well. So again, symptoms and signs of COVID-19, stress cardiomyopathy. Again, it's quite a non-specific chest pains, shortness of breath, and palpitations. Again, nothing very specific there, but quite common symptoms. And again, if it's significant stress cardiomyopathy, it could cause hemodynamic instability. And the pathophysiology of stress cardiomyopathy, essentially, it's due to any form of stress, emotional stress, physical stress. So COVID-19 could probably lead to both types, isn't it? So emotional stress of the illness as well as physical stress from the virus itself, for example, and it leads to catecholamine surge, and it specifically affects the heart, apparently causing some microvascular dysfunction, leading to this so-called cardiomyopathy. Again, as far as the ECG is concerned, it causes this quite a typical type of ECG where you can see the so-called T inversions, very giant T wave inversions in most leads on the ECG. And when I see this type of ECG in a patient, I think to myself, yeah, it's stress cardiomyopathy until proven otherwise, essentially. Cardiac biomarkers, again, troponin levels, quite significant. It is increased, but you can see as compared to a patient who has ST elevation in mind, the increase of the troponin levels are not as significant. So your troponin levels will not be markedly increased in stress cardiomyopathy as compared to a patient who is, for example, having an ST elevation myocardial infarction. Diagnostic-wise, echocardiogram is quite significant. So it's called apical ballooning syndrome, where the apex of the left ventricle balloons out, and there is basal hypercontractility. So for cardiologists who perform echocardiograms in this patient, we see this quite typical echocardiogram finding. Again, treatment-wise, there is again no specific treatment for stress cardiomyopathy or Takotsubo cardiomyopathy, broken heart syndrome. However, if your patient is having quite significant hemodynamic complications, sometimes there is indications for mechanical support. Unfortunately, in this country, we don't have those kind of devices. So in other countries, for example, they have the left ventricular assist device, LVAD as they call it, as a temporary fix for patients who do develop this stress cardiomyopathy. But again, the good thing about stress cardiomyopathy, of course, is that it is a transient illness. Again, once if you can support the patient over a few days, the cardiomyopathy resolves, it's self-limiting, and usually majority of the time the patients do recover their left ventricular function. So that there is a good prognosis as far as stress cardiomyopathy is concerned. So the last bit of my talk today is the so-called collateral damage of COVID-19. And I think it was about a month or two ago, I came across this very, very nicely written article in one of our local papers, actually written by a senior registrar in rheumatology. But I think it's quite, I think it's, we can pretty much generalize it to all forms of medicine and cardiology as well. Unseen victims, collateral damage of COVID-19. And that is very, very significant. And it's quite sad to see the state of affairs sometimes as far as the collateral damage is concerned, because what we see all these specific cardiac complications. We see the MIs of patients who are having COVID. We see myocarditis. We see Takotsubo. We see stress cardiomyopathy. But sometimes we don't see the real damage that's been done. And there are a few reasons as to why it happens. And one of the most common reasons and one of the most disheartening reasons is that patients don't come to the hospital with disease, with symptoms. You can see it's quite a nice slide here. Over the years, the symptom to door time, you can see in 2014 to 19, the symptom to door time in hours is quite low, isn't it? But in the COVID-19 era, you can see it's almost double as far as the time that patients take to come to a hospital is concerned. And it could be due to many reasons. It could be simply because of the fear of contracting COVID-19 by coming to the hospital. I know most of my patients have this problem as well. They don't come to the hospital. They are worried that if they come to the hospital, they might get COVID. Another possibility that could also be is that there is no way to come to the hospital, especially during this whole curfew lockdown period. Public transport was hit. There was no way of coming to the hospitals, where we were not having enough ambulances, maybe, where the ambulances were diverted to treat COVID patients and to bring COVID patients into the hospitals, and other patients were left to their own devices as far as getting to the hospital is concerned. So I'm pretty sure it's multifactorial as far as delays are concerned, but definitely something to think about, isn't it, as to patients coming to the hospital late with symptoms. Obviously, if you come late, especially with, for example, a heart attack, a myocardial infarction, as I said, the later you come, the more damage that would have been done. And over time, and this is in Europe, we noticed that during this whole COVID-19 pandemic, the amount of procedures that are done as well has reduced. So you can see even in STEMI patients, even doing an angiogram, because of the so-called delays, there have been 27% of the time there has been some sort of reduction or stopped an angiogram in a STEMI patient. That's quite a significant number. Even in a patient with a non-ST elevation in mind, the percentage is higher. Reduction or stopping an angiogram because it has not been done because of COVID, 38% of the time. And the delays are quite staggering. And even more staggering is the number of delays and the waiting times that has increased in patients who are waiting for so-called elective procedures for more chronic illnesses. For example, chronic coronary syndromes, elective cardiac catheterizations, TAVI, mitral valve repairs, etc. So these are the so-called elective procedures that we do, not emergency procedures, but elective procedures. More than 90% of the time, there is some sort of a reduction or a delay in performing these procedures. And waiting times in surgeries are dramatically increased over the last few the last couple of years because of COVID-19. And you can see the projected waiting times is staggering. And this is in the UK. And for all types of surgeries, including cardiac surgeries, the waiting time is going to increase further. And this is in the UK, and I'm pretty certain in Sri Lanka as well, it's going to be the same, where the waiting times for routine surgeries is going to be longer and longer, and that will cause a lot of collateral damage to our patients as well. And what will happen if this treatment delays do occur? And this is again from research, you can see that if an elective procedure is delayed because of the treatment window due to the COVID-19, so if that patient does not get that procedure untreated, the outcome is going to be quite scary, isn't it? There's going to be a huge impact on their health. Even if there's a delayed outcome, you can see compared to a patient who gets that treatment on time, you can see that if the delay does occur, the prognosis is not going to be very good. So unfortunately, this is the so-called collateral damage that we don't speak about, but I think it's important to know and to think about it as well. COVID-19 is causing disaster upon disaster everywhere, but this is something that is not spoken about very often. but something that we need to always keep in mind. A couple of last words on the vaccine as well. So that's pretty much the only hope I feel as far as the pandemic is concerned. And I think by vaccinating the population, we can somehow get things moving. So take-home messages: have a high degree of suspicion for cardiac complications of COVID-19. Cardiac injury in COVID-19 is multifactorial. Awareness and diagnosis or management is different cardiac complications of COVID is important, and effective vaccination can prevent death from cardiac complications. Thank you very much, and over to you, Suneth.
Right, thank you, Dr. Chamara, for a very comprehensive and quite detailed overview on the cardiac complications during COVID-19. Chamara, I do have a number of questions for you. And also, in the meantime, if anyone else would like to ask Dr. Chamara a question, please raise your hand on Zoom and I can unmute you to carry on, or send it to me on text also. Chamara, a few of the most important questions I've got here. One repeated question was, how long after the recovery do we have a risk of cardiac complications for COVID-19?
But it's a good question and a difficult question to answer, quite frankly speaking. So there is no hard and fast rule as to when cardiac complications can occur after COVID-19. It could be, it could occur during, after, and there is no specific duration. But our biggest concern, of course, is this whole complication during the whole infective period of COVID-19. So, for example, the myocarditis and the stress cardiomyopathy, the acute coronary syndromes, for example, occur during this whole infective period. But I can't specifically tell you that you are at less risk after this amount of period. We are still this. The problem with COVID-19 is it's so new to us that we don't know enough about it yet to give you a concrete answer as to how long. Is it weeks, is it months, is it years? We have absolutely no clue as to how long the legacy effect of COVID-19 would last, unfortunately.
Right, understood. Thank you, Chamara. And again, there were quite a few concerns raised about the use of aspirin in COVID-19 patients. Now, the commonest one being, can we use aspirin for COVID-19 patients with mild cardiac symptoms? And if so, for how long?
Yeah, again, it's a bit of a controversial topic, to be honest with you. So again, we don't know enough about it to give a correct answer, is what I could say. So there's a lot, again, everything about COVID-19 is things that we are learning on the go. We are all new to it. There's no expert on COVID-19 anywhere in the world. So we always go by so-called anecdotal evidence. So again, if you go and if you read about COVID-19, there are quite a few articles on the use of aspirin. And in particular, low-dose aspirin has been found to be very useful in prevention of thromboembolism in COVID-19, especially arterial thromboembolism. So what we don't know is by giving it, but we always, in our line of work, we always go by so-called risks and benefits. So the benefit of preventing death and from cardiac disease in COVID-19 by giving aspirin, there is some evidence that there is by giving low-dose aspirin, there is benefit in preventing death. What we don't know is that by giving aspirin to these patients, is it going to cause them some harm? So the biggest problem with aspirin, of course, is bleeding complications, GI bleeding, hemorrhages, etc. So are we going to risk our patient getting some GI hemorrhage by giving them aspirin, or is that going to outweigh the benefit by preventing cardiac death? So again, it's not in any guideline. There is no real guideline, but the consensus generally is that by giving aspirin, it does prevent cardiac complications. It prevents cardiac death. So I think it's not a bad idea to be on aspirin after some sort of a cardiac, some sort of evidence that your patient has had COVID-19 related problem.
Right. Thank you, Chamara. That actually made some sense. Also, there was some interest generated with regards to myocarditis. And one of the questions raised was, what can we do? I mean, or what can we prescribe for? Basically, what steps can we take for the prophylaxis of myocarditis?
Prophylaxis. Well, there is no medicine, unfortunately, that has been found to be helpful in preventing myocarditis. It's something, again, it's very heterogeneous. We cannot predict which patient is going to develop myocarditis and which patient is not going to develop it. As we said, there are certain patients who have the so-called risk factors who are more prone to develop myocarditis and other complications as well. But there is no medication until now, at least, that has been shown to prevent myocarditis from occurring, unfortunately. Right. Whoever discovers it will be a billionaire.
This is true. This is true. One more question we need to pick your brain on with regards to myocarditis is what time window post-vaccination is the highest risk for this? I mean,
yeah, that's a good question. So yeah, good question. So what they say is the first week, 1 week, 7 days. That's when, if you were to develop myocarditis post-vaccination, the first week is the biggest risk factor, the time duration as far as getting myocarditis is concerned.
Right. I saved one question for last. I'm not entirely sure whether it's fair to ask this of you being a heart specialist, of course. But
leave it to you to ask controversial questions.
This is my job, unfortunately. But can taking regular clopid, ivermectin, and colchicine prevent the transmission of COVID-19?
Ask again. I'm sorry.
Yeah, can the regular intake of clopid, as in
clopidogrel,
ivermectin, and colchicine have any effect on the prevention of transmission of COVID-19?
Sounds like a nice cocktail to me.
Yes, exactly.
Again, we have to follow the science, Sunet. So again, unfortunately, if we were to go by international, there is not enough research done in this country for all these medications. So we don't know enough to say whether this is going to prevent COVID-19 or complications, etc. So there's a lot of talk about ivermectin. I know a lot of social media talk as well. But if I were to say something, it will be very controversial. So all I can say is that I have to leave it for the scientists to find out and let us know whether giving certain medications like ivermectin, like colchicine, clopidogrel, or whatever is going to prevent this type of diseases from complications from occurring as well. But unfortunately, I'm not well read enough to answer that question.
Right. Okay. Chamara, there's one more question. This actually is a very practical question asked. Very simply, we tend to see a lot of patients with tachycardia following COVID-19 with pulse rates around 120s per minute.
Yes.
As primary care practitioners, what can we do in such such a situation for are
you talking post-COVID patients?
During infection as well. I mean, they do have. So
it's like this. So the tachycardia during infection, that's essentially the physiology, isn't it? So it's a stress response to tachycardia during COVID infection or any infection. It's just a physiological response of our body. So in that case, to be honest, it's quite a common problem. It's something that we are always asked to deal with as well in practice, in clinical practice, in not only COVID patients, but in, for example, ICUs where we get septic patients, for example, who have tachycardias, and cardiologists are asked to come and see, and they say, this patient's having tachycardia, what do we do? And the answer that I always give is, that's why are you worried about a tachycardia in this patient? He's having fever, he's having infection. I would be happy that he's having tachycardia. That means his body is responding. That means that's a normal physiology. He's physiologically responding to infection. So in a patient who's having ongoing infection and having a tachycardia, I don't worry too much. As long as the patient is hemodynamically, otherwise blood pressure and etc. is okay, I'm not too concerned about the tachycardia. But
Right.
I do get
Chamara,
certain patients.
let me just interrupt you for a second there. Dr. Deshant, who asked me this question, just clarified saying he meant post-COVID with tachycardia.
Post-COVID, yeah, exactly. So that definitely is that's a very sensible question. So I also do have a few patients who come to me post-COVID who have persistent tachycardia. So this is what we call a inappropriate sinus tachycardia in that case. Again, this is probably more of a legacy effect of COVID-19. One thing I would obviously do in them is, if they have not had one already, probably assess for some sort of a myocardial involvement. There's possibility of subacute myocarditis even after COVID infection. So an echocardiogram will be very useful in them to find out what their LV function is, number one. And even if the LV function is normal, having this persistent tachycardia post-COVID is probably not an ideal thing in that case. So we can try to reduce it by prescribing certain medications. So beta blockers can be useful if their blood pressure is okay and there is no other contraindication. Another medication that I give for patients who have sinus tachycardia, inappropriate sinus tachycardia, is ivabradine, which is available, and it's useful to reduce their heart rate, and it has good long-term outcomes as well.
Right. Thank you, Chamara. That actually makes sense. Thank you. One last question we have. We've been asked whether it's advisable to use rosuvastatin in COVID patients, or if there's any adverse effects of using it as a lipid-lowering drug.
I wouldn't use rosuvastatin purely for COVID-19 patients. I don't think there's any evidence to support that. But if your patient is already a dyslipidemic patient who is on rosuvastatin and their liver functions are normal, I see no reason to stop it. But specifically starting rosuvastatin in patients with COVID-19, there is, as far as I know, there is no evidence for that.
Right. Thank you, Chamara. Thank you very much. One last question as I was about to wrap up. What are the alarming signs and symptoms of cardiac involvement? Yes.
I'm sorry, I couldn't follow you.
Sorry, the last question before I wrap up. What are the alarming signs and symptoms of cardiac involvement in post-COVID patients?
The alarming signs and symptoms. So it's again, there's no real symptom. There's no real alarming sign and symptoms. So if I were to say, for example, if your patient is having angina kind of symptoms, that's something to consider. Exertion or chest discomforts, etc., which can potentially mean that they have some sort of cardiac involvement. Significant shortness of breath on exertion, again, post-COVID, because the problem with patients is that these are very non-specific symptoms, and it could be due to many things. What I see a lot of in my practice these days, I do get quite a lot of patients who are referred and they come directly also post-COVID. It's quite funny nowadays. We get so many patients come and the first thing they say is, "Doctor, I'm after COVID and I'm having this," because we never used to hear this before. But they come with fatigue. So fatigue it's very broad, isn't it? It's a very broad symptom. It could be breathlessness, it could be tiredness, it could be many things. So but if I ask some direct questions, and if I feel that, for example, if they say they cannot walk a few yards, even they feel very breathless, then that could be alarming. But also remember that it doesn't always mean that it's heart involvement. It also could be lungs, isn't it? So because your COVID patient may have had some sort of a pneumonia, and that would lead to some sort of a lung damage or a permanent lung damage, sometimes fibrosis. That could have been the shortness of breath. But it'll always be good to exclude any cardiac involvement in your patient who is complaining of persistent shortness of breath on exertion or chest discomfort on exertion. That would ring some alarm bells in my head as well, which would, and I would always perform an echocardiogram in these patients.
Right. What you ended with is actually our next question. Dr. Shehan would like to know whether it's mandatory to do an echo in elderly patients post-COVID.
I wouldn't say it's mandatory, but I would say if your patient is symptomatic, yes. I think it's always a good idea to have a baseline as far as an echocardiogram is concerned, it doesn't mean all patients should have it. I think we'll all be overwhelmed. But I think if your patient is having shortness of breath or chest discomforts, especially on exertion, and you're suspecting that they may have had some sort of a cardiac involvement, and this subacute myocarditis also is quite common. So I think it's a good idea to do an echo in those kind of patients.
Right. That was the last question, and I think we can wrap it up there. So, ladies and gentlemen, this was Dr. Chamara Ratnayake speaking to you on the complications, or on the cardiac complications post-COVID. On behalf of the NCD Committee of the College of GPs, Chamara, thank you very much for your time on a Sunday evening. It was a very informative and a very good lecture on what we can do. Also, I would like to thank our chairperson for her mediation, and I would like to thank each and every one of you for tuning in once again on a Sunday evening. I hope this helped all of you. Thank you very much. Good night.
Thank you very much to Sunet as well for moderating, and thank you for the college for inviting me as well. Thank you very much.